Good morning. Hello. My name is Julia Burnier, and I'm an investigator and researcher within the Cancer Research Program of the Research Institute of McGill University Health Centre in Montreal, Canada. And firstly, I'd like to thank you for the opportunity to give you a brief overview of what I'm doing in Montreal and how it relates to ocular melanoma and some of the exciting projects that we have. I think it's great that this symposium is going forward, even despite the current global situation. And so I thank you again for the invitation. Our university and research institute is really facilitating translational and clinical research because our new hospital and Glen site allows for our hospitals and research institutes to all be under one roof in one site. So at the new Glen site super hospital in Montreal, we have our clinical hospitals, pediatric and adult facilities. We have our state-of-the-art research institute, a dedicated cancer center, as well as supporting infrastructure for platforms and scientific research. And this really allows us to do bench to bedside translational research all under one roof with our clinical and scientific colleagues. My research, which is within the Cancer Research Program, focuses on molecular biology and cancer biology. And in particular, I have an interest in ocular melanoma. And so that's what I'm going to talk to you a little bit about today and some of the exciting projects that we have. My research focus is really under three main umbrellas. One of the things that we're doing is trying to understand the molecular mechanisms underlying metastatic disease, and in particular, trying to understand how cells go from a primary location very specifically to secondary organs, so what we term site-specific metastasis. And as you know, ocular melanoma has a remarkable tropism to the liver. And so one of the things that we do in the lab is try to understand the communication between tumor cells and the microenvironment of the liver organ. The second thing that we really focus on, and I'm going to talk a little bit about today, is designing clinically feasible approaches to monitor disease course through liquid biopsy. And some of you may have heard the term liquid biopsy and be familiar with this approach. I will briefly go into it, and I think you will have had the chance to also hear about this earlier in the symposium on a talk on circulating tumor cells. And I think this is a really exciting field, a new direction that we're going in that could have big impact for patient care. And lastly, we work to uncover the role of how the molecules that we find within liquid biopsy that I'll discuss actually play a very active role or have mediate the progression of tumors and metastatic disease. And in particular there, we really focus on therapeutic targets. Recently, we've teamed up with an engineering group that is going to help us design therapeutic vehicles for us to be able to bring potentially some exciting molecules closer to clinical testing. So what are liquid biopsies? Again, I think you will have heard a little bit about this, but this is a really exciting new field. And simply put, liquid biopsies is the use of biofluids such as the blood to sample tumor or disease molecules. So in the area of cancer, we really talk about our ability to use biofluids to sample, isolate, characterize, and study tumor disseminated molecules. And liquid biopsies aren't only in the blood. We can use saliva and urine and ascites, and in the eye we can use aqueous fluid and vitreous. But the most commonly studied is the blood. And it is so because it is very minimally invasive to take a blood draw and to isolate and characterize disseminated tumor molecules. There's three main types of analytes that we talk about. One is circulating tumor cells, which I think you will have heard about, which are tumor cells that detach from the primary tumor and enter into circulation. And they can be identified because tumor cells have differences in density and morphology and size than normal cells of the body, as well as cell surface molecules that can be used to recognize them. There's also circulating DNA and other types of nucleic acids, and this is a big focus of my research. These are small fragments of DNA that are released by tumor cells, enter the circulation, and we can identify them based on their genetic characteristics, which are reflective of the tumors that they stem from. and extracellular vesicles, which are small membrane-derived vesicles that reflect their cell of origin. I like to think of them as mini cells or mini representations of the tumor cells that they derive from. And in recent years, really exciting research has shown that extracellular vesicles are likely one of the communicators or mediators of progression, metastasis, communicating between the cells of the microenvironment where tumors will grow. And I think what's really important about liquid biopsy is that it gives us a lot of insight into tumor heterogeneity. We know that tumors are not homogeneous. They have different clonal populations, cells with different histopathological and different genetic characteristics. And those different characteristics will also dictate differences in behavior. So by being able to sample a representation of all of this, I think is really important, and it gives us insight into not only the cell populations within that primary tumor, but if there's more than one tumor, if there's micrometastatic disease. So I think it's a really powerful way to study disease in a robust way. And there are many applications of this kind of approach. As I said, it's a non-invasive biomarker for early detection of disease. It allows us to monitor patients non-invasively over time, which I think is a really crucial gap right now in our clinical monitoring, that we cannot biopsy patients over and over again. So we are unable to really sample disease over time. And I think this is a really important feature of liquid biopsy, to detect disease, relapse, or metastasis prior to it being clinically seen. To evaluate early treatment response, one of the things that we're doing a lot in the lab now is looking to see if we can use circulating tumor DNA and other types of liquid biopsy to evaluate treatment response in preclinical modeling. And I think we have compelling evidence to suggest that that is the case. And ultimately, really, the goal is to modify treatment according to the molecular changes that we see. And so if we're able to track and monitor patients closely, then we're able to modify treatment in a really personalized way. And I think this is really the basis for personalized medicine. So one of the types of work that we do, and I wanted to just give a little brief snippet of one of our studies, is an analysis of liquid biopsy looking at circulating tumor DNA from a preclinical to a clinical study with a very consistent methodology. And the aim here really is to see if we can detect tumors and their progression in ocular melanoma through sequential non-invasive biopsies, and importantly, in a cost-feasible way. So what we did is we've conducted a really thorough in vitro cell culture analysis to detect DNA that comes from tumor cells and DNA that's embedded within those vesicles that I mentioned, also coming from tumor cells, to see if they reflect the genetic components of those of that DNA reflects the DNA of the tumor cells and of the primary tumor from which they come. And what we've found is that this is a really good model to study disease and to study circulating tumor DNA. So then we moved into a clinical study where we've enrolled close to 50 patients now. I think we're at 45 with uveal melanoma and some with nevi. And we were looking to see if we could detect circulating tumor DNA, and if circulating tumor DNA would inform us on disease, on response to treatment, and as a predictor of disease progression. And I think here we have some really exciting data to suggest that this could be a really important biomarker. We're doing this at the McGill University Health Center, and we've partnered with the Centre Hospitalier de l'Université de Montréal, which is our French hospital in Montreal. And now we've opened up to include the Cleveland Clinic, Arun Singh, and Wills Eye Hospital, Carol Shields, and now São Paulo Medical School as well with Rubens Belford. And I think it really exemplifies how coming together we can enroll more patients, we can get more data, and it can be really more significant and make more progress. This is a rare disease, so by coming together, we can really make more of an impact with our research. So we can use this type of methodology and approach to answer lots of questions. We can use this approach to answer clinical questions, such as, can we use liquid biopsy and circulating tumor DNA to monitor disease course, in terms of tumor burden, progression, metastasis, and I think importantly, at what stage is this clinically significant? Is this going to be more important for detection of disease or for monitoring or as a biomarker of treatment efficacy? And maybe this is even going to help us stratify patients to particular treatments based on what we see in liquid biopsy. But importantly, and I'm a basic researcher, I'm a cancer biologist, we can also understand the disease better. So can we identify circulating tumor DNA in all of our uveal melanoma patients? And does this give us some insight into mutational profile and their genetic component of their disease? So can we genomically characterize these tumors through a liquid biopsy, which I think would be very powerful? And to do so, we need to compare the genomics of tumor tissue to that of the circulating material. And that's why I'm excited to see other researchers also looking at liquid biopsies, be it circulating tumor cells or circulating tumor DNA, because I think together we can get some exciting data. So that was a brief kind of introduction into what we're doing. But I think in something like uveal melanoma, we really need to come together and see that it's a multifactorial approach. I'm excited to hear about the research being done by colleagues all over the world that can help bring our clinical diagnosis, our histopathological correlations and characterization, molecular genotyping, biomarker studies, and liquid biopsy all together so that we can come up with more personalized treatment decisions to better treat and monitor our patients with uveal melanoma. So with that, acknowledge the people in my lab. These wonderful faces that you see here are the talented members of the lab that I have an opportunity and privilege to work with every day. You see there my lab address, webpage, and my email address. And thank all the people all the sources of funding that have helped us to accomplish what we've accomplished over the last few years since I started this laboratory, and to continue to make progress in the ocular melanoma and cancer biology fields. Thanks very much.